The views expressed in this podcast do not reflect those of our training institutions or the APA. The information discussed is intended for educational purposes only and is not intended for diagnosis or treatment. Enjoy.
Hello, welcome to the American Journal of Psychiatry Residence Journal podcast. I'm Barrington Hwang, one of the media editors. I'd like to formally introduce our guest, Dr. Terako Amison. Dr. Amison is currently an assistant professor of psychiatry at Vanderbilt. Her career background includes medical school training at University of Alabama at Birmingham, residency at Baylor College of Medicine, and her career interests include community psychiatry, psychotic disorders, and a specific interest in seasonal affective disorder. Thanks for coming on to the show with us.
Thank you very much for having me. I'm glad to be here.
And Dr. Amison and I don't have any financial interests to disclose. So I guess tell us a little bit more. What is seasonal affective disorder? How can we distinguish between that and other types of mood disorders?
So seasonal affective disorder, I would say, is a type of mood disturbance that is affected by a particular time of year. So the classic type of seasonal affective disorder is the onset of mood symptoms that typically worsens in the fall and winter, but then improves in the spring and summer. Typically, a person has to demonstrate this pattern of mood symptoms for at least 2 years. The other distinguishing feature is that when you consider the person's history of mood disturbance, the seasonal episodes occur much more often than the non-seasonal episodes.
That's interesting. Sort of in the fall to winter and then remitting in the spring to summer. And then can it be a part of bipolar disorder, like in a manic episode?
So yes, so you can also see a seasonal pattern in bipolar disorder or mania, but it's much more prevalent to see a seasonal pattern with major depressive episodes.
Okay. We think about seasonal affective disorder in the cold, dark, and winter months, but can it be also in the more summer or hot or bright months as well?
Absolutely. So the more common variant is fall, winter onset with improvement of mood in the spring or summer. But yes, people can actually have a spring summer variant. And in that case, mood symptoms get worse in the spring and summer. Part of the problem with the spring summer variant is maybe some heat intolerance that causes people to have more trouble with that time of year and would be anticipated to improve once fall starts. Okay.
It definitely seems that light and kind of our circadian rhythm are definitely affected with different changes in the seasons as well as temperature. Could you talk a little bit more about how light or other things in the seasons affect our mood?
So sure, we think about our circadian rhythm as being a type of internal clock that helps to regulate our sleep-wake cycle in approximately a 24-hour increment. And so the thought with seasonal affective disorder is that there's decreased sunlight that occurs in the fall and winter, which causes disruption in the circadian rhythm. And that disruption is what manifests as depression and mood changes. Some other theories behind how light impacts mood is some thought that lack of sunlight leads to a vitamin D deficiency, and low levels of vitamin D might contribute to depression. There's also some thought that alterations in light exposure also affect, serotonin and melatonin levels, which then in turn leads to people to have mood disturbance or sleep disturbance. Melatonin is thought to be a useful treatment for seasonal affective disorder to target the sleep component by kind of resetting that clock and causing people's sleep cycle to normalize.
You mentioned that as a treatment. Are there any other treatments that we think about for seasonal affective disorder?
The best treatment is exposure to natural light. And the recommendation is to get outside at least half an hour a day and preferably engage in some physical activity while being out of doors. And believe it or not, even in overcast weather, it's worthwhile to get outside because people can still benefit from the sunlight. However, when weather doesn't permit a person to be outside, then using a light box can be very helpful. And, a person can choose any model of light box that they prefer. The main requirement, is to choose a light box that has a UV filter and to choose a light box with a strength of light bulb that's approximately 10,000 lux. Typically, the light box should be placed approximately 16 to 24 inches from the person's face. And you use it initially 20 to 30 minutes once a day with an option of even going up to twice a day.
What about any medications we think about for seasonal affective disorder?
So, the common strategies in regards to medication management for seasonal affective disorder are usually bupropion or some SSRIs such as fluoxetine or sertraline. Therapy can also be beneficial for the treatment of seasonal affective disorder. And we primarily, think about using cognitive behavioral therapy, also known as CBT, with the goal being to really motivate people to get outdoors and to be active despite the weather, and also just motivating people to cultivate coping mechanisms to deal with their seasonal variations in their mood.
Are there any things that happen seasonally that the DSM does not include in criteria for seasonal affective disorder?
So DSM says that you don't include factors, for example, like in the fall winter variant, you don't include, for example, a person who says, I'm depressed because I am laid off every winter. So you don't consider that to be a seasonal depression.
Any other behavioral interventions we can do for people who experience the summer variant?
Summer variant of depression, sounds like the literature is saying yes, then it would be perhaps limiting some of the light exposure. Also for people who are heat intolerant, controlling their temperature or controlling the temperature of their environment to make their environment cooler.
Okay. Are there any interventional treatments that we think about for seasonal affective disorder? Things like ECT or TMS or ketamine?
I didn't see any indication for any of those modalities, but I would assume that with any case of severe depression, if the individual did not get a response, to therapy or med management, then it would be reasonable to move on to, TMS or ECT, in the case of a refractory depression, even with a seasonal onset.
How did you get interested in treating and working with people with seasonal affective disorder?
Seasonal affective disorder is so prevalent that it has just become one of the things that I frequently screen for. And one of the things that, I recommend for all of my patients who have determined a seasonal pattern to their mood symptoms is, let's not wait. So I encourage all of my patients, let's be proactive. So for example, now is the time of year that I really start to say to my patients, hey, let's start being proactive. Go ahead and get your light box. Let's go ahead and maximize your medicines. Let's get your mood as stable as it can be. Because for most patients, it is such a predictable pattern. I think it just makes sense for clinicians to try to stay ahead of it and be proactive in treating it.
Are there any particular risk factors or demographics that are more susceptible?
Women are more likely, people between the ages of 20 and 30. To me, this is stuff that is just risk factors for depression in general. The primary risk factor for developing a seasonal affective disorder in particular is a person's locale. So people who live either far north or far south of the equator are more likely to experience the fall-winter variant of seasonal affective disorder. Being close to the equator is protective against fall-winter variant.
Well, that's good to know. I guess any other final thoughts? I know a bunch of trainees are listening to this.
Well, so the best advice that I can give to those who are early in their psychiatry careers is to never shy away from an experience. Residency is the prime time to learn all that you can. You want to leave residency feeling well-rounded in med management and psychotherapy so that you can be prepared to treat a wide range of patients. Looking back on my career and looking back on my time as a resident, if I had one regret, it would have been avoiding cases or situations that I thought were difficult at the time. In retrospect, it is the difficult or challenging cases that yield the most learning.
It's really helpful to do it in a supervised learning environment where I can get some guidance.
Absolutely. The training period is the time to be exposed to difficult cases because the supervision is there.
We appreciate your time with us, Dr. Amison. Thank you for just working with us and your impact on many of the medical students here at Vanderbilt and on many others is really valuable. We appreciate you listeners as well for listening to the American Journal of Psychiatry Residence Journal podcast. Feel free to follow us on Facebook, Instagram, Twitter, and YouTube, and feel free to click subscribe.
All right. Thank you very much.
Look forward to tuning in next time.